Hi, my name is Susan Sabo-Wagner, and I'm going to talk about the comprehensive strategic and marketing plan that I'm presenting for mitigating health inequity with a value-based care model. The practice that I'm talking about is my own practice. It's called Oncology Consultants, or OC for short, and we're a community-based practice that started in Houston, Texas, that provides oncology and hematology services. We recently moved out of Houston and to include Corpus Christi, Texas, and Rockport, Texas. The services we provide as an overview are medical oncology and hematology, radiation oncology, radiology, retail pharmacy, lab, and research. Currently, we have 12 medical oncologists, 2 radiation oncologists, 12 advanced practice providers, which include 11 nurse practitioners and 1 physician assistant, 360 full-time employees, 14 medical oncology locations, 2 radiation oncology locations, 2.5 imaging centers, 3 retail pharmacies, and that includes all 3 locations between Houston, Corpus, and Rockport. And the certifications and accreditations that we all acquired over the years are COPI, NCQA, CLIA, ACR, ONCC, URAC, and ACHC. COPI is a quality oncology practice initiative, which I will talk about in a little bit greater way. And NCQA is a medical home program. CLIA is lab services that are certified for Medicare. ACR is a radiology accreditation program. ONCC is certification for oncology nursing. And URAC and ACHC is a certification and accreditation for pharmacy. The model of care that we utilize is a hematology and oncology care model. We are outpatient ambulatory patient care. We use a team nursing structure where registered nurses are primary patient care providers in the chemotherapy and infusion therapy area. We work closely with all disciplines, including physicians, advanced practice providers, and many more. The licensed nurses, or LVNs, medical assistants, pharmacy technicians, and nurse navigators, and also nurse practitioners can be support roles. Quality Oncology Practice Initiative is one of our certifications. COPI for short is a quality program designed for outpatient oncology practices, and it fosters a culture of self-examination and improvement. This is a certification that we prepare for every 3 years, and we've been certified for approximately 9 years. We will be recertifying this year. Oncology Nursing Society, or ONS for short, is a professional association of more than 35,000 members committed to promoting excellence in oncology nursing and the transformation of cancer care. We all have all policies and procedures based on Oncology Nursing Society's guidelines, and we also use NCCN and other cancer pathways. Oncology Certified Nursing, or OCN, is a recognition of certification. We take very seriously our nurses that have achieved certification in their oncology certification. For our strategy, we're going to be looking at mitigating disparities in health inequity. For our strategy plan, we're going to use 3 years to get this off the ground. Year 1, we're going to take forming the team will be the initial step. The team will consist of leadership, of course, from the practice, a project manager, contracting specialists, because we are going to utilize value-based care planning to help get this off the ground, RN, data analyst to help us decide what data we need to capture and how to capture it and how to present it, nurse navigators, and providers. Study population and survey patients and literature review will be a part of this year 1 as well. We're going to have to determine the disparities that are affecting our patient population in all of our various areas. So we'll have to survey all of our patients to see what exactly we're looking at in terms of disparities. And we'll also do a literature review to see what kind of disparities we should be expecting as well. We're going to develop analytics tools to be able to measure those disparities and see in different areas of town and different zip codes and different other types of socioeconomic related issues to help us understand what exactly the disparities that we will be looking for. We will research resources and interventions for the disparities because we are in quite a large, broad area. Houston is the 4th largest city in the country, and it also has one of the most diverse populations as well. And so we need to make sure we have enough resources to meet all of the potential disparities. We will then match the resource to the need before the treatment starts, i.e. chemotherapy. That way patients have the best chance of getting to treatment and having the best response to treatment. And then we will measure data to see how we did in matching the resources and getting patients into treatment on time. Year 2 of our strategic plan, we will assemble data to present to our initial payer for the pilot program. We will present it, and we will have consistent meetings to make sure that they understand what it is we did to get to the point that we are here. And we will propose a value-based model, including performance-based payments based on mitigation of disparity per patient. Hopefully, we will at that point solidify the contract for a pilot program. Year 3, we will assemble data from payer partnership to show successful outcomes, market to other payers within the OC organization, and propose similar value-based plan to each additional payer. And hopefully at that point, we're solidifying more than 2 or 3 contracts. In a strategic plan, we're using a SWOT analysis to ensure that it's successful. And strengths of this plan would be increasing patient access to care, which is our number one goal overall. Reducing disparities to ensure that our patients are reaching equity in care. Enhancing value-based payment structures for OC while performing valuable services for patients. Weaknesses would be if we had weak or inconsistent or missing resources for certain disparities, and lack of clean baseline data. Opportunities would be development of internal programs for health equity and patient advocacy, and community outreach opportunities, prevention programs, resource development, and cancer screening programs in underserved areas. Threats to our plan would be competition outside oncology practices other than our own, or payers opting out, preferring other value-based care plans, or resources available are not sufficient to impact patient outcomes if what we're finding to help our patients really just isn't quite good enough. Our marketing plan is going to consist of several areas. First, we'll look at the competition, looking at external and internal market analysis. External, we're going to look at 3 major areas here in Houston, and that is going to be MD Anderson, Texas Oncology, and Millennium Oncology. They are 3 of our biggest external competitors. Internal market analysis is to look at our staff in general and our providers and make sure that we do very good education of what health inequity is and how we are going to tackle it and what each role is for everyone. The payer mix, we'll take a look at that. We have 11 major payers that we work with within the practice, 5 of which are commercial payers and 6 are Medicare, Medicaid, Medicare Advantage, and exchange plans. That's a 66% of commercial and 34% of the rest. Timeframes for this whole marketing plan would be the first phase, taking about 6 months to start with, is developing survey tools. This is going to be a very important part because this will help us develop our data and our resource location. The next part of phase 1 would be to discuss and have the contract signed by payer 1. That would take about 3 months. And then our phase 2, which is the first year of data collection with our payer 1, and then out to the second payers and third and fourth and beyond. And then ongoing will be our third phase, where we are continuously improving the whole entire plan and continuing to data collect and hopefully generalizing and scaling it out to other practices and maybe other payers. Targeted markets would be our payers, of course, and of course cancer patients meeting the criteria of any health disparity that requires assistance to get to treatment. Outcome measures would be patient treatment adherence, their treatment tolerance, their disease response or progression, effectiveness and compliance with their resource. Sometimes non-compliance is going to be an issue with the resource. Potential disruptions to the plan are ineffective resources and payer disinterest. Our volume projections will, in year 2, begin to rise very slowly as we continue to show the insurance company what we are doing. And then as they start to see the outcomes, the revenues will begin to increase. Looking at $160 per patient per month enrolled in the program, we will see that increase across the year. Our initial growth with payer 1 will slow as we bring on new payers. Highlighted payers are likely to show interest and may sign our proposed contract. If so, this would put 54% of our patient population in the program, or 1,698 patients. If 75% of these patients enrolled, then 1,200 patients would result in $160 per patient per month. Why? This is how I would present to our board of directors Why should oncology consultants participate in this, and why should the payers agree to participate in this with us? Houston is the fourth largest city and one of the most diverse in the U.S. All people have the right to equal and equitable health care, regardless of race, gender, sexual orientation, socioeconomic status, or other difference in demographics. Solid solutions to the complex health disparity issues are not readily available. Attaching performance-based payments for quality care associated with mitigating inequity incentivizes both payer and provider and keeps patient at the center of the focus. Thank you.